So now we come to the fetal heart, the STIC technology. When a pathologist examines the fetal heart, first he looks at the heart from the outside and he sees in a normal heart the two ventricles with an interventricular septum between the ventricles. He sees the two atria and the two vessels, and he examines the overcrossing of the great vessels and the normal course of the great vessels. And for example, in a fetus with an hypoplastic left heart syndrome, you see the difference in the size of the right ventricle and the left ventricle, and also in the difference in size of the pulmonary trunk and the ascending aorta. The next step he done is he cutting the heart by half, and he look at the cutting plane and he sees the ventricles, and the pathologist have defined planes for examining the fetal heart, and he sees the left ventricle and the small right ventricle, in this case with tricuspid atresia and intact with a ventricular septal defect. What we do in ultrasound is we do a two-dimensional ultrasound and we move the transducer, and in our brain we rebuild, because of moving the transducer, the heart in the different planes, the 4-chamber view, the 5-chamber view, the 3-vessel trachea view, and the arches when we change the transducer from the horizontal plane to the sagittal plane. Because the heart is a more spatial organ, it is much more easier to examine the fetal heart using a volume technology. And what we want is, we look at the heart, we cut the heart by half, and we look at this cutting plane using the STIC technology, and we see the two ventricles, we see the movement of the two AV valves, and we see the two atria, and we see also the inflow of the inferior vena cava. And this is the moment we understand the function of crista dividens, and we see also the inflow of the pulmonary veins into the left atrium. The next is we look for the outflow tract, and always we speak about the overcrossing of the great vessels. Especially for beginners, it is very difficult to understand how overcrossing is. And from the left ventricle, the aorta is going to the right and then back to the left as an aortic arch, whereas the pulmonary trunk going directly from the right to the left. Because we work in a volume and we have a data set of the volume, we see directly the overcrossing using color Doppler. And as an example for a heart defect, this case of hypoplastic left heart syndrome, we cut this heart by half and we look with using surface mode. In the STIC technology, we have a large right ventricle, we have nearly no left ventricle, but we see the two atria. So you see the left atrium with the dilated pulmonary veins. You see the right atrium, there's a large foramen ovale, because all the blood coming into the left atrium must go to the right and then in the right ventricle. So it's a classical case of hypoplastic left heart syndrome, mitral atresia and aortic atresia. When we do volume ultrasound, all of you know we have two steps. First step is the volume acquisition, and we have different kinds of volume acquisition, 3D and 4D or STIC technology. And the next step is the volume display. When you examine the fetal heart using STIC technology, and you want to see only the fluid-filled organs, and for the heart these are the ventricles, the atria or the vessels, you always use the minimum mode. And when you want to use minimum mode, be aware that your B mode image must be more dark than you normally scan. If you want to see in the STIC volume also the color, you have a combination of vessel visualization and B modes. This means the surface structures. You use a glass body mode. And for this, you must know that color must be more longer in the image, so increase the power for the color. And the next thing is the visualization of only the surface structures. The same as for the face or for the hands, you use the surface mode, and this means you see all the different surface structure of the heart when you cut the heart and you look at these different structures. And you have heard before that the most important plane is the A plane, because the A plane is your original plane. In the B plane, you see how big is the angle And you see if you have all the structures of the heart inside your volume. So it's the second important plane. It's a 90% perpendicular plane, and you see we have all the heart structures in our volume. In plane C, I like to look at plane C. If I see anything, I know the quality of the volume is good. And if I have artifacts, I see the artifacts in plane B, and in plane C, I realize, okay, the quality of the volume is bad. But for example, in cases with heart defects, always you have problems with movements, or the baby is not in the wrong position. So you are able to work with the volume even if the acquisition quality of the volume is not as good you thought. When you use 3D or 4D technology, you work always with the different buttons on your ultrasound machine. And you have these three important buttons, X, Y, and Z, and you rotate with these buttons in your volume. And one of the very important buttons is the scroll button, because you scroll through the volume and you perform like a virtual examination in the volume. And these buttons have the same function as the software on your computer. And this was the questions before the course. How many of you work with the software on the computer, because you have the three images here and you have all the different buttons on the machine also on your software, and normally you learn on the computer and later you work on the machine. How can we use STIC in our daily work? And of course we use STIC in our daily work. One thing is we use it in the sectional planes, and the second thing is we use it with a different render modi. We start with the sectional planes, and one of the most advantages is performing a virtual examination. We start at the level of the upper abdomen, we scroll through to the 4-chamber view, we get the 5-chamber view with the normal course of the aorta coming from the left ventricle. You see the valve of the aorta, then the pulmonary trunk is coming from the right ventricle going to the left, and you see the ductal arch and the aorta arch, both arches on the left to the trachea, and you see the pulmonary trunk valve, and you have all the normal heart structures, also inflow of the pulmonary veins into the left atrium, and you exclude all the major heart anomalies, and you could repeat this with color, and then you exclude nearly 90% of all severe heart defects. So for teaching purposes, and we use it always when we perform fetal echo courses, and we train our pupils for fetal echo using these multiplanar imaging. And the next thing for the sectional planes is multiplanar imaging or tomographic ultrasound imaging. And with this, we could reduce the frequency, and then you have a much better image of the AV valves. You see the open and closing movements of both AV valves, and this exclude, for example, these cases with AVSD. And later in the afternoon, I put a volume on your computer with in case of an AVSD. Looks very similar to that Rabi showed you before. And also for teaching things, we use multiplanar imaging or TUI, because for beginners in fetal echo, it is very good to have these multiplanar image. You have a normal 4-chamber view. You realize this is this plane. The next plane is going to through the 5-chamber view, or the aorta is coming from the left ventricle, and the next is through the pulmonary trunk. So you know we have a distance between the 4-chamber view, the 5-chamber view, and the pulmonary trunk, and you have all the three different planes in one image. It is good to understand the normal anatomy or the normal physiology in the fetal heart. We could do the same with color. And we have in red the diastolic filling of both ventricles, in blue the 5-chamber view, and also pulmonary trunk and aortic ductal arch and aortic arch. And we see the 4-chamber view, and the arches are on the same side. They are on the left side. So we have a normal fetal echo using glass body mode. This means B mode and color together. And Rabi show you this OmniView, and when we draw this virtual line through the left ventricular outflow tract, I put the line directly into the left ventricular outflow tract, and on the right side you see what happens. And virtually we rebuild easily the aortic arch. And okay, it is a nice tool, but for people who want to train fetal echo and who want to learn fetal echo, it is easy to understand how the different structures of the fetal heart are to each other. And sometimes people have difficulties to understand the terminology of fetal heart defects. Sometimes you have a systematic of heart defects who have a normal four-chamber view and abnormal great vessels and this is the case of a very severe heart defect with a completely normal four-chamber view. And you see a normal four-chamber view with a normal diastolic filling of two ventricles, but it's a very severe heart defect. And you will understand if you go to the great vessels, you see we have no overcrossing of the great vessels and both vessels coming from the right side. So it's a double outlet right ventricle, and a beginner in fetal echo, and we use it in our echo courses, understand it's a heart defect. Even if it is a very severe heart defect, maybe you have a normal four-chamber view, but you have abnormal vessels, and clearly you see as we're using color Doppler in this tomographic ultrasound imaging volume. And the next is also severe heart defects, detecting and screening ultrasound with 23 weeks. We start in the plane of the four-chamber view, normal four-chamber view, normal diastolic filling of the ventricles. We go to the great vessels, the aorta coming from the left, going to the right. The pulmonary trunk is coming from the right ventricle, overcrossing of the great vessels. What's wrong with this heart? If you look carefully, you see the apex of the heart is on the left side, but both arches are on the right side. So it's an isolated right-sided aortic and right-sided ductal arch, and the vessels are very close to the sternum, so it's no thymus there. It's a microdeletion 22, Q11, and right-sided aortic and ductal arch. So it's an example of a normal four-chamber view, but abnormal course of the great vessels. And in this image, you see all the typical features of these severe heart defects. And again, a very severe heart defect, it's an Epstein's anomaly. And this is the original image, the start image where I acquired the volume, and clearly you see all the typical features of this Epstein's anomaly. The low insertion of the septal valve of the tricuspid valves, the paradox movement of the ventricular septum, and this is only the right ventricle, this is the left ventricle, and again we see also a pulmonary trunk, pulmonary stenosis, because the pulmonary trunk have a thinner diameter than the aorta. But we are able to get images which shows us nearly a normal four-chamber view, or maybe a beginner will think this is a normal four-chamber view. And you must be aware this is the annulus fibrosus. You have an oblique view of the four-chamber view, and using volume ultrasound, and I show you later same volume of this case, you will understand how important this is. And the referral diagnosis for this heart defect was hypoplastic left heart syndrome. And we see a difference in the diameter between the left and the right ventricle, but we have a normal contraction of both. And at the end, it was a Schoen complex. It was a mitral stenosis and aortic stenosis, but the baby get a biventricular repair after birth. Now we come to the different render modi in the fetal heart. And first we start with normal anatomy, and with surface mode you see all the different structures. The right ventricle, the left ventricle, the ventricular septum, the movement of the both AV valves, the inflow of the inferior vena cava below the foramen ovale, dividing the blood flow to the right and to the left atrium. Then we scroll through the volume and you get the left ventricular outflow tract with the valve of the aorta. You see the movement of the aortic valve. You see the normal diameter, no dilatation after the aortic valve. You see the movement of the tricuspid and mitral valve, and you understand how close the relationship is between the mitral valve and the aorta. And with normal surface mode, you see the aorta, and using the combination of grayscale and color Doppler information, you get in glass body mode. volume, and you see the blood flow, and when you scroll through this volume you understand the diastolic filling of the ventricles, the left ventricular outflow tract, and the overcrossing of the vessels. And it's very good to understand the position of the vessels to each other, the aorta going to the right and goes back to the left as an aortic arch. Normal anatomy. Normally we look at the four-chamber view, and we have the ventricles, the valves, and the atria, and then we like to have it as a video clip. But you have an x-axis, and when we rotate the volume via the x-axis, we look from the ventricles as the both valves, and you see the tricuspid valve and you see the mitral valve, and the better the quality of the ultrasound is, the better is the image, and with the new machines we could count the 3 and the 2 part of the valves. So we have these normal valves with the leaflets, and we see from the ventricles of these 2 AV valves. When we do it the same in this case, and this is the case with an Epstein's anomaly, and we have an oblique view through the heart, and for us it looks like an image as a normal four-chamber view. And even if you use it as a clip, and if you are not an expert, you didn't realize the paradox movement, we rotate the volume via the x-axis, and clearly you see on the left side we have a valve, but on the right side we have nothing, because the valve is more deep in the right ventricle near the apex of the heart, and especially in cases with valve anomalies, for example Epstein's anomaly, AVSD, it's a very good tool, and we use it in our daily work to look how if we have only one valve, if we have 2 valves, how is the function of the leaflets going, are the leaflets going, shows more to the left or to the right side. Some people like the sagittal planes for examine the arches, and we have an aortic arch and the great vessels to the head arising from the aortic arch. We have a ductal arch. The ductus comes from the pulmonary trunk directly behind the sternum, and we don't like these sagittal planes. With volume ultrasound it's much more easier to get images like this for the arches than with 2D. We like more the horizontal planes, and you see both arches have the same diameter, using surface mode, using minimum mode with focus only on the fluid-filled organs, and you get an information about the vessels. You see the diameter, and it's very quick, and you can say if the arches are on the left or on the right side. And these are unusual planes for us, but for a pathologist or for a pediatric cardiac surgeon it is much more familiar. And this is the left ventricular outflow tract. The best volumes, the images of heart volumes you get was around 28 or 30 weeks. This is 31 gestational weeks, and you see the left ventricle, the right ventricle, the ventricular septal, it's a four-chamber view coming from the side. And you see the course of the aorta coming from the left ventricle. You see the movement of the aortic valve, and the aorta is going to the right, and in the next plane going back to the left. Again, it's more an apical four-chamber view. The left ventricular outflow tract, and even it is 36 gestational weeks, we are able to get a good image of the left ventricular outflow tract using surface mode. This is a new tool called VCIA. We do VCIA during the examination. We have a thickness. I choose always 2 millimeters, and we get a more spatial image of the heart, and we could scroll, do the normal examination, and you see the four-chamber view, the left and the right ventricular outflow tract. And especially when you use VCIA in the first trimester, because of the summation of the image, you have a much more better image of the four-chamber view or the great vessels in the first trimester. This is a transvaginal scan with 12 weeks, and made the early fetal echo much more easier than with the normal 2D. And it's very fast. It's not a STIC technology. You use VCIA as a 4D technology during your normal examination. How we can use the STIC technology in heart defects. I will give you some examples for this. This is an example of an VSD, ventricular septal defect. We have the 23 gestational weeks. We have a right side, we have a left side. You see the ventricular septum. And here clearly you see the VSD. You have an overriding vessel getting the blood from both ventricles. Again, malalignment VSD with an overriding vessel. You see the small VSD below the aorta, below the aortic valve, left ventricle, right ventricle, 24 gestational weeks. An example for an AVSD, diagnosis with 21 gestational weeks. You see this common AV valve, and you see that it's a balanced AVSD. Both ventricles have the same diameter, so the AV valve shows us the opening movement in both ventricles. The ongoing course of pregnancy, again 28 gestational weeks, AVSD, the same case, with a good outcome after birth. And I told you before that we use also the rotation of the volume in cases with AVSD. This is a normal 2D scan of AVSD. This is a surface rendered scan of AVSD using STIC technology. And always we have a more sharp and better image using the STIC technology. We see the AV valve much better than in 2D. We see the different structures of the heart much better. And then we have a normal heart. We rotate via the x-axis, and clearly you can see that we have two AV valves. And in case with an AVSD, you see that we have only one valve. We look from the ventricles from below at the AV valves, and you see we have only one valve compared with a normal heart where we have two AV valves. This is a very good tool using STIC technology in daily work in the detecting of heart defects. And this is a combination of an AVSD with color Doppler, and you see the called H form of the diastolic filling. Both ventricles getting the blood. You see the AVSD here, and we are not able to demonstrate the insufficiency because of technical artifacts, but the H form is much easier using the STIC technology than the normal 2D scan. And again, in case with an Epstein's anomaly, this is a normal course. You see the deep insertion of the tricuspid valve. This is a surface rendered image. You see the deep insertion of the tricuspid valve. You see the paradox movements. You see this large atrium with the arterialization of the right ventricle. And then we rotate this via the x-axis. We look at the valves on the left side. You see the mitral valve, and this is a very new volume 2010 with a better quality. And here you can see we have two leaflets as a mitral valve, and on the right side we have nearly nothing because the valves are not in the same plane. So you can compare yourself, and it's very easy to make a prognostic, give a prognosis for this heart defect. Transposition of the great arteries. Because we are in the volume, we are able to see the ventricles and the parallel course of the great vessels in one image, and you see the pulmonary trunk coming from the left, aorta coming from the right, and these parallel course. And again, with minimum mode, focus on the fluid-filled organs. When you acquire a volume like this, you must decrease the grayscale of your B mode before acquiring the volume, and for combining with color, you must increase the persistence of the color, so that the color is longer in the image, and then you get a good quality of the color in a STIC volume, that you have the diastolic filling of the ventricles and also the systolic filling of both vessels and the parallel course of the vessels. And this is a minimum mode of a case within transposition of the great arteries, normal four-chamber view. And because we are in a volume, we scroll through the volume, we rotate the volume, and clearly we come to the parallel course of the great vessels. and we get images which looks very similar to angiographic images, and especially when we counsel patients together with a pediatric cardiologist. Normally, pediatric cardiologists didn't understand our ultrasound images, but they understand these volumes because for them it is very similar to angiographic images, and the parallel course of the great vessels is good to demonstrate. And double outlet right ventricle, nearly normal for chamber view. Maybe you can see the small VSD here. Good development of the both ventricles. And using minimum mode, you see both vessels with a good diameter. The pulmonary trunk is bigger than the aorta, coming from the right side, parallel course of the vessels, and double outlet right ventricle. And again, the combination with color is in glass body mode, and you see the blood flow through the ventricular septal defect. And then you can scroll through the volume, and you see the course of the great vessels, both coming from the right side. But the original for chamber view was nearly normal. I showed you this image of a classical hypoplastic left heart syndrome in the beginning of my talk. Right ventricle, left atrium, dilated pulmonary veins, and nearly no left ventricle. This is a different one, critical aortic stenosis with a large left ventricle but no contractility of the left ventricle, and a beginning of endocard fibroelastosis. We have a normal contractility of the right ventricle. We have movement of the tricuspid valve. We see the two atria, and the third typical hypoplastic left heart syndrome, small left ventricle, no contractility of the left ventricle, very thick wall of the ventricle, and a normal right ventricle with normal contractility, and the two atria are there. The case of the tricuspid atresia with VSD in a pathological case I showed you in the beginning of my talk. Atretic tricuspid valve, VSD, small right ventricle, the bigger left ventricle. Generally the prognosis is good, and this is a combination with color, and we see in red only the filling of the left ventricle, no blood flow across the tricuspid valve, but we have only a filling of the right ventricle via the ventricular septal defect. And there's the opposite thing on the right side, pulmonary atresia with intact ventricular septum. We have two ventricles, but the right ventricle shows us no contractility. The left ventricle shows us a contractility. We have a decreased movement of the tricuspid valve, but normal movement on the mitral valve. You see the foramen ovale going to the left. And using color Doppler, we have nearly no blood flow across the tricuspid valve, only a small insufficiency. We have only blood flow in the left side, and in this case it also ventricular coronary fistula, and you see the blood flow in this ventricular coronary fistula too. We go to the great vessels, and one of the malformations in the great vessels is a common arterial trunk. We have this common arterial valve here. We have the common trunk, and then the common trunk divide into the big aorta and the tiny pulmonary trunk, and we get an image which looks very similar to the pathological image. Again, double outlet right ventricle using minimum mode, and when you rotate the image, which looks in an AP direction as an X-ray or an angiography, you have images which looks very similar to the angiographic mode for a pediatric cardiologist. It's up to you how you rotate the volume. Be aware that you didn't lose yourself in the volume. And classical case, right-sided aortic arch, combination grayscale information and color Doppler, glass body mode, and you see this arch. But you can use it also with minimum mode. And the advantage in minimum mode is that you didn't decrease the frame rate of your image with 97 Hertz. The quality of the image is much better than using color Doppler, and also the power you bring to the fetus is less than using color Doppler. The referral diagnosis in this case was right-sided aortic arch, and you see one arch is going to the left, one arch is going to the right. So maybe the referral diagnosis was right, but you are in a volume and you play with the volume and you scroll through the volume, and clearly you can see we have a third arch going back to the left. So it's a double aortic arch and a ductal arch. So after birth, these double arch will be removed, and the ductal arch closed, and then the baby is healthy. And the diagnosis was made with 20 weeks, in this case only using the STIC technology. It was normally with 2D ultrasound we made the diagnosis for double aortic arch around 28 weeks, because then the double arch, which have always not the same diameter as the right arch, it's big enough to detect. So we come to the conclusion. For us, STIC technology is not a method of detecting ultrasound. This is not the tool of the technique. We use STIC technology for teaching, especially for courses, for trained people in fetal echo, and very good tool for the offline analysis. We didn't send the volumes to other people, but we discuss with the pediatric cardiologist or between us at the volume without the patient for second or third opinion, because if you are not sure in the diagnosis, sometimes it's very difficult for the patient. You do the scan and you discuss what kind of heart defect it is. And we have new tools, and they allow us new advantages in the future. So I think for the fetal echo, STIC is always the future. Thank you.